Hi, everyone. Welcome to Building Confidence and Bridging Gaps Through Education. My name is Ashley Addison. I am the project manager for the HSJCC Secretariat. I am joined by my colleague Snehal, and we will be your moderators for this session. Before we get started, I will review some quick housekeeping notes, and then I'll introduce our speakers and begin the session. I'd like to draw your attention to the bottom of your screen. You can use the chat feature to submit questions. Please type question in all caps in the chat before your question to make it easier for us to find them. The presenters will be taking questions at the end of their presentation. We will do our best to ask as many questions as we can during the time that we have. Please ensure your microphone is on mute until the Q&A portion of this session. Please note that we will be recording this session to upload to the conference website for future viewing by those who have registered for the conference. You will have access to the platform for 90 days following the conference. If the presenter has documents for the participants, direct them to the session page and the links will be found there. So we do have a notes page in the platform if you want to take notes, and we can also make the slides available after the session. We kindly ask that you complete a short evaluation at the end of the session. Your feedback is appreciated and will be used to inform future events such as this conference. Lastly, we'd like you to respectfully ask all of those attending today's session to engage with each other thoughtfully and always consider the impact of your words and interactions on others. As moderators, we will not tolerate abusive or inappropriate behavior and will ensure that anyone who engages in such behavior is removed from the session. I would now like to introduce our presenters today for the Building Confidence and Bridging Gaps Through Education session. We have Michelle, Pan, Jill, and Anne, and Kathy Halovenik. They will be sharing some polls and some great discussions, and I will now pass it on over to them to get started.
Thank you, Ashley. So sorry for the bit of the delay there. Of course, the day continues with a few tech glitches, and we may go over our 12 o'clock time, but not by too much. Anyway, we're going to talk today about building confidence and bridging gaps through education and talk a little bit about our role. So both Michelle and myself are ABI navigators in the province, and some of our slides will just briefly touch on what that entails. You're also going to hear a lot of next slides because we're going to have to rely on Snehal to do that. So next slide. So we're going to start with a quote: "Education is the passport to the future, for tomorrow belongs to those who prepare for it today." So we really felt that that kind of sets the tone for the theme of our talk, because really what we need to do is we can provide you with a bit of education, but we're doing that so that you can prepare to work with individuals who have a brain injury in your own service sectors. We obviously realize that within a talk that's less than an hour, we can't cover everything. So you're going to see a lot of links throughout our presentation. So that's the homework on your end to take the slide presentation later on and at your own pace, look at that information. Next slide. Today, we're hoping to go over some acquired brain injury 101, importance of identifying brain injury in your particular setting. We're going to showcase some positive education experience and then also have a chance to discuss some case files. And then, of course, like I mentioned, there'll be quite a few links to connections. Next slide. So we're going to pull up a brief poll, hopefully. It's just 2 little questions, so we're not going to take too much time on this. And I don't know if Ashley is there. I think she tried it earlier. There we go. So again, it's quick to answer, so we won't leave it up too long. We'll give it another moment and then we can show the results. Okay, so we can pull up the results. All right, so pretty almost even mix, not quite. But so what we're hoping today is that by the end of the talk, if you answered that you were novice or good, that you'll feel like you can bump yourself up a little bit. And for those who are experts, that's wonderful to see. And we hope that you'll go away with maybe a few more tips and tools to use in your work. There was another question, but I think that they were going to put it in two. But basically, it was just to see if you, yeah, so do you currently work with individuals who have a brain injury? So again, it's a quick answer, so we won't leave it up too long. And then we'll pull up those results. All right, so we're preaching to the converted here. So most of you have worked with individuals with brain injury, so that's good to see. So again, I don't know, we were going to ask that poll at the end. I don't know if we're going to have to, because I think most of you know it. So we'll go to next slide. So acquired brain injury, I'm going to go over all this. Some of you may know it, but that's the umbrella term. So looking at individuals who have sustained an injury after birth and generally not degenerative in nature, you're going to usually hear two terms, traumatic or non-traumatic. Non-traumatic tends to be more medically based. So these are things like a stroke, an anoxic injury, which might be from an overdose or a brain tumor. And then traumatic is more an external force or blow to the head. So this might have been caused by a fall, being in a motor vehicle or sporting injury or accident, or being struck directly by an object. At the bottom, we just have a link about a position paper. So they are working to try and have brain injury recognized as a chronic condition, because even though there is that kind of initial injury, it does impact somebody across their lifespan. And you also will hear terms such as mild, moderate, and severe, and those are more medical classifications to denote the type of injury or the extent of the injury, not to say that someone with a mild injury isn't also experiencing a lot of issues. Next slide. So these are some of the common changes you'll see after brain injury. It is not an extensive list, but we just try to pull out some key ones that most people would see. We often see changes with memory, particularly with short-term memory. These are individuals who have challenges with attention, so being able to sustain their attention, difficulty processing information, and it takes them sometimes a longer time. They have a hard time with planning and organization, their thoughts and their day. They often make poor judgment calls. They may not have insight to the fact that they have these challenges or that they have a brain injury. They struggle with mental flexibility, so being able to change thought processes or go from one topic to another. And then they may be challenged with communication, and that can be expressive or receptive. Behaviorally, we see changes with social awareness. So a lot of times this is with our being able to read social cues in social situations. They have a hard time being motivated, getting started. They have difficulty controlling their emotions. These are people who often go from 1 to 10 really quickly with anger, or often very tearful. They're impulsive. They tend to act instead of thinking things through, and they can get frustrated really easily. Physically, you may see changes in sensitivity. So these are people who may be sensitive to light, to noise, or to touch. They often have weakness on one side of their body. They can suffer from fatigue. So this might be physical fatigue, or can also be cognitive fatigue. And then challenged with their balance and coordination, particularly fine motor coordination. And then they may show signs of neglect, and that may be because of visual disturbances that are affecting their ability to see on one side, or because of some of those sensations. Again, we're just touching on this. If you want more information, there is the link to the Ontario Brain Injury Association at the bottom. Next slide. So as a result of those challenges, some of the things that you might see in your work is that these are individuals who are often late or not showing up to appointments. They're not following through with tasks that you may have assigned to them. When they are with you, they may appear restless, or they seem to appear like they want to leave. They may interrupt conversations or make inappropriate comments. They have difficulty getting started on a task, or on the flip side, they get stuck on a thought and they have a hard time moving on to the next topic. They may engage in repetitive comments or actions, and again, their emotions may seem a bit extreme. We've talked about can't versus won't here. So it's not to say that there aren't individuals who won't do something just because that's their personality. But I think it's safe to assume that for many individuals, they can't, or they need help to do these things because of the nature of those challenges that we talked about. it becomes really frustrating on their end and also on the provider's end. Next slide. So this is looking at the domino effect. So you can't know what you don't know. So we know there's a lot of research and data to support the fact that there are a number of individuals with brain injury in different sectors of the society, but the education, the screening, and the disclosure is inconsistent. So if you don't know what to look for, you're not going to recognize the signs of a brain injury. This may then lead you to misinterpreting an individual's presentation. You may then miss the opportunity to provide certain accommodations and strategies. And then you may miss out on being able to provide some good referrals and resources for these individuals. Compounding this is the fact that individuals may not themselves have insight into their injury. So this may be because of the nature of their injury and they lack that insight, or just because they've never been diagnosed. So there are quite a few individuals who are living with undiagnosed brain injuries. Next slide. So we're not going to show this video, but if you have a chance, it's a really nice summary. So it focuses more on youth in the criminal justice system. The first minute and a half does a really good summary of what I've just talked about. And then if you want to look at the whole 12 minutes, and it goes into a little bit more depth as to some of the ways you can work with these individuals. Next slide. So just a couple of slides on our role. So as ABI navigators, one of the main things that we try to do is be that connection between the healthcare system and the person with lived experience. And the healthcare system is really a broad area that we're talking about. So this might be from hospital, ministry, or community supports. And when we're looking at community supports, it's really into those other social sectors of support and multi-ministerial supports. And then obviously with the person with lived experience, it's also incorporating the caregiver, who often in these cases is a key component. The main thing that we're trying to do is to promote and improve system access and capacity. We're hoping to improve outcomes and a person's overall experience. Next slide. So there's 4 main roles that navigators try to accomplish. There's 13 of us across the province, and each of us may do our role slightly differently, but these are kind of the key components that we'll touch on. Education is probably the biggest thing that we do. So by being out here today and educating people on some of the talks. Resource navigation is about that connection, so getting people to the right resources, and that might be, again, anyone from those little bubbles I showed before. So it could be somebody from, a nurse from a psychiatric unit calling us for resources. It could be a person with lived experience or a parent. We don't have a chance to do direct case management because there's just not enough of us, but what we do tend to get involved in is complex case coordination. So this is where an individual who has a brain injury is also dealing with other issues such as justice involvement, substance use, or mental health issues. And we'll be called in to try and help bring people to the table to try and kind of brainstorm and problem solve some ways to get resources for these individuals. And then through those works that we do, sorry, just go back for a minute. We also look at identifying system gaps and barriers. So that kind of almost comes out of the work that we do. And then because we have the ability to speak to the people in all these different areas, sometimes then we're able to work on how do we then go about kind of closing up those gaps. So for instance, for today, we're hoping to close up a gap by educating people. At the bottom of the slide is the link if you're looking to find your local navigator in your own geographic area. Next slide. So just through our education efforts, just want to touch on some of the key ways that we think it's important. So whether we're doing a one-off session like we're doing today, or a number of us sit on committees and networks that we attend regularly, it's about bringing awareness about the need to consider ABI. So anyone who sits on Transition from Custody Network with me knows that I often will bring up about the fact that, hey, you forgot to mention ABI or to consider that. It allows us to advocate. So for all those people with a brain injury, people with lived experience, they can't go to all of these committees and networks. So we try to be that voice and bring their needs forward. And then also by trying to forge a way towards integration and a more holistic view of care. So we know that services for brain injury are limited across the provinces. So how do we still ensure people are getting some help where they're being seen? Next slide. All right, so I'm going to hand it over to Michelle, and we're going to get into some of those intersections with different comorbidities.
Thank you, Kathy. Well, anyone can sustain acquired brain injury. Some groups have a greater risk of sustaining a brain injury, with significant gaps in care for those who fall in the vulnerable populations and have an ABI. Why are there gaps? 3 top reasons. Brain injuries are underreported. Symptoms can overlap, making it difficult to decide what is or determine what is the root cause. So you need to peel back the layers. As well, many clients with co-occurring disorders fall through the cracks. They're bounced between agencies. In the slides that follow, we'll look at examples of how consistent education has proven successful in closing some of the gaps. I'd like to do a shout out to this event. There are 2 ABI posters and another concurrent session on traumatic brain injury, which you can meet this afternoon. So there is a desire to learn about ABI, and it demonstrates that the education is working. Kathy and I reference a lot of research, and for the most part, it is Canadian, in itself a positive sign of education. Next slide, please. We've divided the presentation to address specific interactions of ABI. However, this is not reflective on real life. People are multidimensional. Many situations, there are multiple factors going on. Next slide. Thank you. Many risk factors for brain injury are also factors for involvement in the criminal justice system. And we heard about that in the talk this morning, such as being young, male, engaging in high-risk behaviors, and using substances. More on that specific risk factor later on. Studies show that ABI prevalence is higher in incarcerated populations than the general public. The stats is 42 to 66% of inmates and male, and approximately 33% of female inmates have had at least one brain injury. And damage to that frontal lobe of the brain, which controls impulses, can have a significant impact on an individual's ability to consider alternative responses, learn from past behaviors, and appreciate the consequences and maintain self-control. All issues which could make a person more likely to have contact with law enforcement in the first place and inhibit an individual's ability to reintegrate and increasing the likelihood of recidivism. Next slide, please. With education, service providers will know to screen and identify for brain injury. We'll talk about a screener later on. Then offer supports in institutions, part of parole and community-based services. There's a high need for ABI education, and it's difficult to move forward without joint support of the Ministry of Health and Ministry of Corrections. Success requires buy-in and funding. It's difficult to incorporate into existing ABI support services. There's a need for quick response, capacity, and establishing connections prior to discharge as high risk of losing the individual. We'll talk about that in the case study. What's been done? The ABI system navigators have had booths at the health fairs and institutions to introduce offenders to information about ABI and community partners and to facilitate reintegration into the community. There's support with release planning, a positive process of information sharing where discussions led to education sharing, which led to involvement in ABI system navigators on community integration planning tables, and the Hamilton Wentworth project. The system navigator connected individuals who were to be released to ABI an ABI community worker. Next slide. For the sake of time, we'll take 3 ideas for now and return to this case review in the Q&A for more discussion. Would you please put hashtag number 1 as the, if you have responses, or you can put up your hand and speak directly to us. So case review, I'll read it for you. Individual with repeated minor offenses is unable to remember court dates and was found in contempt, repeatedly fined, and finally incarcerated. They were assaulted while being held and had a second injury. The client was dismissed from jail without notice at night and lost to community support services for several weeks. What is the discussion point? How could education have had an impact on the outcome? So please put up your hand if you'd like to speak directly or put into the chat hashtag number 1, please. I think we're a quiet group today. So The solution, Judy, I see you.
Somebody has to break the ice. So the first thing was when the client is forgetting the court dates. That's the first point of if somebody was attuned to thinking there could be a brain injury history there, they would look at, often that's assumed that the person is being defiant or disinterested or combative, as opposed to maybe they just forgot. So I think with some education and intervention could have been to provide some supports to help remember. So that's, I mean, I could go on, but I'll let other people speak, but that was the first thing that struck me right off the bat.
Yeah, identification. Thank you, Judy. I see that Allison, your microphone is not working. Would you like to put into the chat? And I see from Rory that system to help remember or remind of court dates. Yeah, was the person really willfully disregarding the order, or do they need to be connected with community programs to use some strategies?
If I could interject, the other point would be client dismissed from jail without notice and lost to community support. Again, if there's identification that the person might have a brain injury, maybe there could be that proactive connecting to community supports so that there's that communication so the person is not lost.
Yeah, it is difficult, especially if the time is up. They can't hold a person past that moment in time to be released in the morning, but to contact those agencies prior to. So maybe there's someone who would be able to meet them at the door. We all are flexible, right? We do try to bend the rules a little bit, maybe, flex your day and then be able to meet that client at when they would be released. Thank you. So Allison wrote, education about the wraparound supports that are available for navigating the court and justice system. They need ABI supports and court support diversion. Our justice system would benefit greatly from a wraparound. I have educated some at EMDC. I'm sorry, Allison, I'm not familiar with that short form. But for example, we were notified when they were due to be discharged. That is a beautiful point that ties into Judy. The Eglinton Middlesex detention. Thank you. So our points are, was a person really willfully disregarding the order? Use the mental health courts when appropriate. Know that a person could get into a fight. With brain injury, there is a high risk of sustaining another injury and having those conflicts, making connections. Awesome. Thank you. Well, the next slide is about resources for you, and we do have the slide pack, and you'll be able to go back to them at your leisure. Mental health. Following a brain injury, pre-existing symptoms of poor mental health may be exacerbated by the injury or develop after the injury. The most common issues are anxiety, depression, PTSD, post-traumatic stress disorder, and suicidal thoughts and ideation. Next slide. Due to the nature of brain injury itself, a survivor may have a lack of awareness and believe they're doing just fine. They may have troubles identifying exactly what's going on and will need your help to tease out what's going on. Due to stigma as well, some survivors may identify with having a diagnosis of ABI over mental health. And if a person has poor mental health prior to the injury, brain injury is not going to make it better. Previous coping methods may not work now, and therefore the person needs both mental health and ABI supports to work together to help manage the symptoms. And a mental health diagnosis post-brain injury can get sticky. Symptoms of brain injury and mental health can overlap, and it can be difficult to determine whether the issues are a result of the brain injury itself or something with mental health. The presence of symptoms does not necessarily mean that the survivor is experiencing mental health challenges. It could be related specifically to the brain injury. This is where a diagnosis is key. So education and past present. Poor symptoms management can hinder rehabilitation outcomes. It's very important to identify symptoms of mental health and brain injury and to support the individual with effective best practices as soon as possible. Because individuals with an ABI often require additional support and consideration, ABI system navigators, I see many of you here, are spreading the word of ABI to mental health services with encouraging collaboration, case management, coordinating both mental health and ABI services, and continued follow-up. So the education past and present is available for your perusal when you get the slide pack. We will move to the case review, which is a good news story. So no discussion points here, but some food for thought. An individual with a history of significant mental health, developmental disability, and brain injury. Remember, we talked about people are complicated and there are many different factors. Behaviors resulted in justice involvement and impacting ability to remain housed. All community options were exhausted. The person was placed in mental health inpatient unit. The person was successful in hospital with high levels of structure and supports. The local navigator brought in stakeholders and funders to the table to plan for discharge. With cross-education to all involved, wraparound supports, which someone mentioned earlier, and commitment to ongoing service provision, the individual has been able to live independently. One very important outcome was placement on a vulnerable persons list. Getting to this point took much time and effort, but has proven to be a successful model. So good news story. We'll move to the addictions part. Individuals with brain injury and substance use disorders need support to assist with both the symptom of brain injury and addiction. Why education is needed. Approximately 1/3 of survivors have a history of substance use prior to the injury. There's often a honeymoon period where the amount and frequency of use stops or reduces. But then in 2 to 5 years post-injury, the use increases. Without intervention, many survivors will resume their prior levels of use. So that's using prior to injury, but between 10 to 20% of persons with brain injury develop a substance use issue for the first time after their injury. Thus, post-injury people are at risk for developing a use problem, either because they had one before or because of the vulnerabilities created by the injury. What education is past and present? The current treatments and services need to be adapted to accommodate symptoms of brain injury. This is done by service providers with expertise in substance use and ABI coming together to support the cognitive and emotional impairments caused by brain injury. And here's some of the education that we've done in the past. So case review. Again, it's a discussion point. We'll do number 2 as the feedback. Just while you're listening, think, how could education have helped? An individual with a history of ABI from a car accident attends appointments with addictions counselor at request of a girlfriend. After several attempts, they join the recommended group. They were often late or missed appointments. They never seemed to make it to groups or sessions unless someone dropped them off. They didn't follow through with any of the plans that they made in sessions. After about half an hour or so, they'd start to fidget to the point with other group members were distracted. There were even times that they looked like they might be ready to fall asleep. After 6 weeks of very limited progress, the provider began to question the individual's motivation and discussed that they only seemed to be coming because someone was making them, and perhaps best to discontinue. How could have education helped?
Quieter than the first one.
Not a problem. Used all the gas in the first. Okay. I have understand that ABI can impact attention span and that they reach a capacity. Yeah, top up, need to have breaks to continue on. It's like running a marathon. Sophie, I see that your hand is up.
Yeah, I was going to echo. Oh, Can you hear me?
Beautiful.
Perfect. I was going to echo the same thing in that sometimes motivation can seem like somebody's not interested in doing it, but it's actually their ability to follow through or to remember appointments and do that kind of stuff. So education could help the provider understand what Kathy was saying, that I can't versus I won't.
Mm-hmm. Yes, and sometimes that being dropped off is the way that the person's attend. They want to, but they need that support to fall through. Their brain is not getting that get up and go, and their partner is acting like their frontal lobe and giving them the boost that they need. Observer wrote, a lot of things coming in. That they believe educating and collaborating with others is crucial. As we support professionals, we can share our expertise and specialist supports with one another. Observer, you have gotten our conclusion. Thank you. Provide different ways to engage them. This is Danielle during the group. They need breaks or change in topic. Incorporate movement into the session. Yes, that fidgeting can be a way that the person is paying attention. Providing education, as we previously discussed, is imperative to understanding someone's symptoms, in quotation marks. There are much support workers that can attend such appointments in order to write notes down, cue them back to the conversation, and advocate with and for them. Exactly, having that support person. Sometimes support person is not welcomed into the group, so it's advocating for that support person to be able to attend. And Jenny wrote, letting them know there are no expectations, that we will meet them where they're at. How can we help you get through the challenges that present? Redirect, focus on strengths, and limit too much information at once. Yeah, exactly. It's determining a person's unique communication and learning style. What level is the individual at? Where can we meet them? Beautiful. Thank you. A lot of great participation. Thank you so much. Your participation makes the sessions so much better. All right. Kathy, are you ready to take it away?
Yep. Okay, so we're going to move on to our next intersection, which is ABI among the homeless. And we'll go to the next slide. So education again, so these are again common themes that we're seeing. So we know the prevalence is there. It's about 50% of men and women that are known to have a brain injury. And they are looking at, is this a causal factor? So they know within the research that 70% of those who are homeless indicate that they have had an incidence of their first brain injury prior to becoming homeless, which makes sense. I mean, a lot of these individuals are no longer able to have gainful employment, so their income levels decrease. We know housing is extremely expensive, so that leads to difficulty to maintain rent. Issues with their behaviors can be problematic with landlords or family members who then end up being kicked out of their residences. And the unfortunate part is that the research is also showing that these are individuals who tend to have those more higher level brain injuries. So they fall into that when we talked about mild, moderate, severe. So they tend to fall more into that moderate to severe group. Education is needed also to help those shelter workers. So again, these days, it's not uncommon from the hospital to the rehab center that these individuals are having to be discharged to the streets or to a shelter. So whatever information can go with that person to that setting, particularly if it's to a shelter, to help those shelter workers have some tips and tools on how do I best interact with the individual? How can I present the information so that they have the information. Sometimes it's just how you present it to that individual so that they can make the best use of it. Next slide. Education is coming along in this area. There was a talk actually yesterday that from Windsor area that they're doing some work, so this is good to hear. Canadian Research Chairs is doing some information. There's a look at some clinical care guidelines for this population, and we're also seeing an increase in screening. Next slide. So again, this is just another positive good news case review. So this is called a program called ABI in the Streets, which is from Traverse Independence, which serves the Waterloo Wellington area. So they had approached a shelter in their area wanting to do some education for the staff there. And their initial response was no. And I don't think it wasn't a mean no, it was because they felt that this was not a population they served and they weren't in need of that education. And somehow, I don't know all the ins and outs, they were able to agree to have the ability to screen the individuals who went to that shelter. And through their screening, it was determined that 73% of the individuals self-reported history of brain injury. So that is extremely high. And obviously the management and the workers there took notice of that. And not an overnight program, but in time, they now actually have staff embedded in that shelter to provide community outreach to people who are identifying with a brain injury. So again, great story. If we can see more of this across the province, that would be the way to go. Next slide. The last intersection we're going to look at is intimate partner violence and ABI. And I just want to preface this by saying a lot of what we're going to mention is related to women, and that's just because where a lot of the data goes. Everybody recognizes this is not only to women, that obviously men and people of just different gender base are affected, but we got to go with what we're being able to be provided with. So next slide. So this is a group who is at very high risk of sustaining a brain injury. So about 90% of the injuries that women are sustaining are to the head, face, or neck. They're thrown against an object, strangled, or violently shaken. So any of those can predispose somebody to a brain injury. Of the women who sustain a brain injury, the data is showing 1 in 8 in Canada have sustained that brain injury as a result of intimate partner violence. And those stats, I was at a talk last month, is the same as women who are likelihood to get breast cancer. Many don't know the connection between their abuse and the ABI symptoms. So again, they don't have that own personal education about it. And then a lot of service providers, if we go back to that domino slide, will often misinterpret the signs. So there's a lot of difficulty, and even Michelle talked about it in the mental health, between PTSD and brain injury. So sometimes they're mistaking the symptoms for the emotional distress related to the trauma. And then unfortunately, this is a group of individuals who are in an environment where they're at risk of suffering multiple brain injuries. And brain injuries can have a cumulative effect, particularly if there's not a chance for the brain to heal between one injury and the next. Next slide. The good thing is lots of education is being done. Like I said, I attended a symposium last month that brought together a lot of the workers from across Canada who are working on this. I'm not going to go over all of these. I just want to point out the one in the middle, the Brain Injury Toolkit. It's just gone to its second iteration, so it's newly updated, and it is a toolkit that really looked at getting input from people with lived experience when they were creating it. So pretty nice one. Next slide. This case review is really just to point out that education is needed across the system. So we're not going to do the discussion point. It's a good news, bad news. So this was an individual who was lucky enough to end up at a women's shelter where that worker had some education about brain injury. It sounds like potentially they did a bit of a screening, whether that was formal or just in conversation, and were able to determine that this was an individual who seemed to have sustained a brain injury and had recommended that they go and seek medical assistance. So the individual did go for medical assistance and unfortunately kind of had the door shut at that point. So with this case, we didn't know all of the specific details. So unfortunately, with like a milder injury, those are not necessarily going to show up on imaging. So perhaps that's why the GP said that this wasn't needed. But if that was the reason, I don't think this person went away with a good understanding about that being the reason. And sometimes if there's a long period of time between injury and going to the doctor, and unfortunately with this population, there is sometimes that long period of time, they're not always able to get help right away. Regardless, I think it just shows that when we're thinking about education, we can't just think about the community social service sector. We also have to think about the medical side of things. We assume our doctors know everything about everything, and that's pretty much impossible. So they do get a little bit of training, but are they keeping up on everything that's happening? So sometimes we have to be willing to let the physicians know, hey, here is some information that can, I'm aware of. And those can be tough discussions. I think we put our doctors up on a little platform, and it's hard to second guess or want to provide that of something. But that's where you kind of have to start advocating. Next slide. I'm going to just point out the one at the bottom, the concussion awareness training tool, because that is a tool that could have been made available to that physician. In here, we've just pointed out that there's one for support workers for intimate partner violence. They actually have about 5 or 6 different streams that focus on specific groups. And there is one that focuses on the medical side, so for physicians. Next slide. So like Michelle said, we presented things in silos just for the sake of kind of compartmentalizing the resources and the education and where it's happening. But we know that there's a lot of intersections between all of these groups. And when you're looking for help, it can be hard. And I think it's knowing that it doesn't have to be all or nothing. So whether you're the person who's being asked for help or the one asking for the help, if you can't provide comprehensive care, if you can't take that person onto your caseload, can you provide a resource? Can you provide a tip? Can you do a quick consult? So, can you provide a little bit? It's about peeling back the onion layers. So the link, that YouTube link, talks about a program in Alberta where they actually look at brain injury, mental health, and addictions, and they need to kind of see what's the most pressing thing that you need to deal with, peel off that layer. What's the next thing you need to deal with, peel off that layer. And usually at the end, what you're left with is what the true effects of the brain injury are. Manage what's in front of you. So a lot of today, whether or not you have a lot of education or a little education on brain injury, if you can learn some of the cognitive challenges and some of the quick and simple adaptations to make, that might make a big difference for somebody. And then even though I think we've heard a lot so far in this conference about the need for people working together, and I think on the front line, people are wanting that, the study at the bottom was kind of like almost just a scoping review from 2021, so pretty recent. And they're still finding across Canada, it's still pretty much silos of care. So still people operating in their own thing. So we need to still work on getting that message across and making those changes. Next slide. This case review is actually a program that Michelle's involved with. So in her area, they developed a group that worked with acquired brain injury, mental health, and addiction. So it's a collaborative that was based on risk watch tables. And it's an opportunity for a case to be presented, and then individuals who work in these different fields to come together and talk about how to best serve. It may be a short time, a short bit of service, or there's the opportunity to provide up to 6 months of follow-up for these individuals. So if you happen to be in the southeastern area and you want more information, there's the link to find out more about it and the eligibility criteria for it. Next slide. And I would be remiss if I didn't talk about the neurotrauma care pathways, and Judy's probably clapping. So this is a program that was started a few years ago, and they're looking at developing what an ideal care pathway would be for anyone who sustains a brain injury in Ontario. And they're looking at it from the time of injury right through until someone returns to the community. It is an ongoing work. So when you go to the website, it's not finalized. You're going to see if you go back in a few months, it'll look a little different than it does today. They do, though, have a Twitter handle that can give you a bit more updates. The focus this year has been on some implementation projects. So I've been lucky enough to be involved in one of those. So we are creating a resource library called the Central Link, and we're looking at having resources for a number of topic areas. So if you went on, you would find a justice section, you would find a mental health section, you would find, all these areas that we've talked about today, plus some general ABI education. In Ottawa, they're working on a project on PTSD and brain injury. And then in Toronto, they're working on a project looking at OHIP focused concussion clinic. So like I said, this is work in progress. So by next April, you should be able to see all the findings of that. Next slide. And I'm going to pass it back to Michelle.
Thank you. Yesterday, I attended a talk. I'm not quite sure if it was for everybody, if it was a separate panel. And the person was asked, well, how do you screen for a brain injury? And the individual talked about the HELP screener. It's a tool to identify individuals who've experienced or may be at risk for a brain injury. It's called the HELPS tool. And while it doesn't diagnose, it does provide a way to talk about head injury and may identify need for adaptations and help survivors identify the source of some of their challenges. When using the HELP screener, and you can find the link at the bottom, consider the answers in context of the situation and whether any disadvantages to diagnosis, impact on court proceedings, or lack of resources. The next slide is a visual of the HELPS screening tool. We did plan to show you a video, but we need to make up time just like a pilot. So we're going to zoom through this, and it's a great resource. It talks about understanding the nature and severity of the brain injury, taking advantage of rehabilitation professionals and information from psychological assessments for current strengths, abilities, and recommended supports. So something to watch on your own time. Compensation strategies. They're generally tailored to the needs of each individual, but there are some general strategies that work for brain injury. Likely, these are accommodations that you're already familiar with, and strategies that you use to assist those who need help with executive dysfunction. What to note? All of these skills need repetition. Repetition of a newly learned skill is required to cause lasting neuronal changes in the brain for people post-brain injury and for all of us. So the best practice is that everyone uses the same strategies in the same situations. Wonderful. We are moving along. General ABI resources for you to follow up about different resources. A poll. So I think we'll skip the poll. We found out that 94% of us said that they do support someone with a brain injury. 6% said no. And I'm thinking after all the discussion, we talked about the co-occurrence, that it might be 100% of us who are supporting one individual or more who have a brain injury. We hope that you are feeling more comfortable with brain injury. Good news is that we never stop learning, and this conference is proof of that. There are some ideas on the next slide how you can even be more comfortable about brain injury. Given the complexity of ABI, we hope that we've enhanced your understanding and of the prevalence among the vulnerable populations. Moving forward, you can prepare for the future by reaching out to system navigators. There are many on the table here, and we're friendly people. This is not a one-time offer. Reach out at any time. Okay. Education is so key. Yes. By the way, the transverse study, it was Cambridge Shelter Corporation Bridges originally. Then the screening was expanded to the House of Friendship Men's Shelter in Kitchener. And I was working at the House of Friendship Shelter when the ABI work by Transverse started. That's really neat, Colleen, to be at the front of it. I also have a note here that it's worth noting that unfortunately, houseless culture and street-involved chronic houselessness means that individuals will also experience repeated injuries. Yep, unfortunately, it happens. And one brain injury is more likely that you will sustain another one. Additionally, about question number 1, a person noted, this also speaks to the gaps in appropriate and individualized representation in court. There are a lot of areas that likely fall through the cracks here that could have been caught by an assigned lawyer versus multiple duty counsel. Colleen, I see that your camera is on. Is there something that you'd like to share?
I was just kind of thinking about the piece, because once Traverse had done their screening, and I was still working at House of Friendship Emergency Men's Shelter at the time, they then started assigning folks from Traverse to work with our participants in the shelter. And within the space of about 3 to 4 weeks, you could see significant changes in a more effective, motivated, participatory direction. for the individuals that had been identified and that had begun working with Traverse. So that specialized care that they were able to get from Traverse was really instrumental in being able to help stabilize their situations and to get them to the point where they could take steps forward to obtain employment, stable housing, more stable health, start looking at what they wanted to do with addictions and substance use challenges. So that and all that required was us saying, yeah, well, if these guys are willing to cooperate with you, sure, go ahead and do it. And the changes for some of these folks that we were working with as shelter support workers was night and day. So I was very excited, by the way, when you mentioned Traverse in that, because I had known about that piece. So that was really cool that you caught on to that and mentioned it.
Yeah,
But that
and
was
it
all I
goes
wanted
back
share.
to the opening speaker, Devin Clunas. So he kind of talked about how you have to be willing to take the risk to do change, because that was really outside, like that program's very outside of the norm of the way things would do. And they also didn't get extra funding to do it.
Mhm.
So they were willing to restructure how they fund things. So it wasn't simple. Like I said, like it's an idea and it took a lot, but that's where I think if we can, even if you're not getting the funding, is there a way to do more with less? I know all of us, I think, in social services are struggling with,
And
not
an
enough funding,
interesting thing,
but
by the way, a couple of our shelter support workers actually left the shelter and went to work for Traverse, and we're still working with the same guys they had been supporting in the shelter, only doing the work
okay.
as like case managers or navigators for Traverse with the same guys they'd been supporting as shelter support workers.
Oh,
But
that's
now
neat.
they had the opportunity to really dig deep because they weren't focused on having to support every single one of these guys in every single need. Now they were focused on particular areas. So I think that was probably helpful to making Traverse's program successful too, is that they were able to actually take shelter support workers who've been working with these guys and have built relationships with them and credibility over 2, 3, 4 years, and then put them into this program in order to be able to use that or leverage that relationship to help these guys. Anyway, sorry, like I said, I was just excited that you mentioned it. So it's
Yeah,
my backyard.
thank you though. That's really neat to have somebody who's involved and seen even the ongoing effects. I just want to address maybe one more question that came in from Shannon. So do you have any advice or strategies for individuals who have been discharged from ABI specific services for reasons pertaining to their ABI? So being disruptive to the group, being late, missing appointments, challenging and disheartened to see. So I think that's a tough one, particularly I know in the group settings, it's always that play between the vulnerability of the group and the vulnerability of the individual. I think that's where the challenge is, that some will have funding where they can do more group stuff, and then they're not able to do as much of that. Like this is probably an individual who really needs some one-on-one from a behavior therapist or somebody who could work with them on those specific issues. And that's the real problem. And again, it is like I've seen some situations go really bad when individuals who have behavioral or aggressive behavior are in a group setting. I don't know if that's necessarily the case here, but it is hard. I think if there's a way to have that individual maybe even get a couple of sessions more with one-on-one, some tips. There are some, depending on where you live, sometimes there are behavioral outreach services that can do a few sessions with an individual to help them better manage when they are in group situations.
Thank you, Kathy. I was thinking, one, reach out to your ABI system navigator. Follow that link, find out who it is, reach out to myself or Kathy, and we'll direct you. 2, it's not uncommon. You can attack it by giving the client education about how to best manage strategies, but also the service provider. We've had it that service providers are willing to go back on to support a client with the caveat that an ABI services will be in the mix as well. And then also I've seen ABI service providers recreate that group themselves. They've gone through the training and then have facilitated the group with ABI focus. Now that takes a lot. That takes the time and the money and all that, but that's another way to root around it. I hope that we can help you by linking to your ABI system navigator to get supports for that client.
All right. I know Snehal said that she cannot hear us anymore. So I
I'm
think
still here.
Oh, are you? Oh,
Yes.
Ashley's there. Okay. Yeah. Because I know we're just after 12 and I think there's
No worries.
questions.
Did we want to do the final poll?
I think we were going to leave it because so many people here are already ABI experts.
Perfect.
But we do have the feedback. Well, Judy, I see you're popping back on there. But we do have the feedback for our growth. Would you please give us feedback, the nice and the dirty, so that we can improve the session next time?
Yes, so I will just, since we are at the end, I'll just read off what's to come for the people that are still here. So thank you so much for joining us today. And I want to thank our speakers for their fantastic presentation and for sharing their knowledge with us. As I mentioned, please take a moment to complete the evaluation. If you found this session engaging, helpful, give lots of great feedback. The link can be found on the session description page. We want to thank everyone for their participation and all of their questions. It was a very engaging session, and all of you were a part of that. We'll be taking a 60-minute lunch break to recharge. So we encourage you to connect with your participants, view posters, and check out our exhibitor booths. I'm just going to plug our HSJCC booth. I'm also hosting a networking session on anti-racism at 12:30. So I'd love for all of you to join me there. And a reminder, once again, that we do have a pre-recorded mindfulness session from Mike. So please enjoy your lunch until 1. And when we come back, we'll have our plenary at 1 for Carrie Gladue, Trauma, Addiction, and Transformation, the Carrie Gladue story. So on that note, we'll wish you all a happy lunch break. And I'll see you either at 12:30, my session, or at 1 for the keynote. Thank you so much.